So my official answer is put an ocular preset on your machine. And almost all of them will allow you to do some adjustments to change your mechanical index to make it low. That's going to be my official answer.
You can just say you missed this one slide.
Let me talk about the Lumify one, which comes with standard linear probe.
Yeah. So when I had some discussions with the manufacturers of some of the new generation, and I asked about ocular presets, I didn't get totally confident answers. I think it is the kind of thing where they will be able to do it, but in terms of getting their devices to market, it won't necessarily be available right when they come out. And, you know, all of them have this like ability to push updates to them. And I think they'll be on market maybe before they have an ocular preset. Maybe not. I don't actually know yet for some of the devices. We find that tegaderms just make kids more comfortable. You know, you ask the kid to keep one eye closed. A lot of kids under 5, they can't do that anyway. They close both eyes. And it's just a way of like, okay, I'm holding your eye closed for you with a sticker. You can keep your other eye open with no effort to watch your parent, to watch a screen that we're holding for you. And a screen is really useful. What's that?
That's me in the picture.
Yeah, it could be. Mm-hmm. Could be. Did Leanne take a photo of you for the talk? Okay. And you should try to avoid air bubbles when you put it on. We generally put it on just like you see here, with like leaving the paper on it, which you usually take that paper off when you're putting a tegaderm on. Makes it much easier to remove if you're not having to pick up a corner. And we generally find that laying it on the eye in that kind of orientation, I find that easier. Some people have said they find the up and down easier. Whatever works for you.
Patients prefer when it's like that.
Yeah, and I find they prefer the removal that way too, because then you can remove along this direction and it doesn't like pull your eyebrow in a weird direction when you pull it off. Using lots of gel so that you're not having to press on the eye to get your images is another useful trick. Press too hard, you're going to get a vagal response. You're going to have a patient who really doesn't like what you're doing. And often it's hard to gauge how much pressure you're putting on unless you do something like you put one of your fingers on somewhere on the patient's head to stabilize. I often will, I'll hold the probe in a grip like this and use my pinky somewhere. It also, you're going to find that you're really using small motion to get the view that you want. And so having that kind of stabilization also prevents you from doing these big sweeps and losing what you're getting. You know, when you close your eye, it's really that your upper eyelid, in the cartoon version, both eyelids kind of come to the same amount, but it's really that your upper eyelid covers most of it. And I find the most successful approach is to start just under the brow and bring my probe down. Often have it a little bit on like a temporal kind of alignment, and then just slowly slide down. If I don't get it in that kind of sweep, I'll try to tilt. Instead of just bringing the probe down, I'll try to tilt down and get it. And it really doesn't matter what approach you use if you're getting that nice view where the nerve comes up. And that can be tricky. You're not going to have a standardized hand approach that gets you the nerve in every patient because the thing underneath moves, right? So wherever that patient is positioning their eye will have a different probe approach that gets you that nice view. The zoom feature is really useful when you're evaluating retroorbital stuff, especially the optic disc elevation. As we produce literature that tells you how high is too high, the things you're measuring are 1 millimeter at most. I mean, sometimes they're more, but they're often like, oh, I'm trying to tell the difference between 0.5 millimeter and 0.6 of a millimeter. So that zoom is really useful in terms of accurate measurements. So if we're going to talk about papilledema, just the optic disc elevation component, the only study out there was one from Nate Theismann in 2013. And it created these cutoffs that we often talk about translating to kids, but this was all in adults. And so we often will say, well, a 1 millimeter cutoff is like a very specific cutoff. One thing that I want you guys to keep in mind if you're going to internalize these sensitivities and specificities for 0.6 millimeters as a cutoff and 1 millimeter as a cutoff, is there were 14 patients in this case series, which goes into how wide these confidence intervals are. So sure, 0.6 is 82% sensitive, but it actually could be as low as 48% sensitive. So keep those things in mind.
14 patients?
Yeah. So then our program with Magali, and I hadn't yet put Nir, I haven't gotten you to do much yet. Wait, no, I have. You've done a bunch of rodeo evaluations, and I didn't put your name on this. Wow. So Nir, David Friedman, Magali Gauthier, Adrian Davis, and myself, my apologies, Nir, have been doing this retrospective study. We've been scanning eyes for a long time, for like 6 years that our program's been around, but most of the time we've been scanning them for optic nerve sheath diameter because we used to believe in that a lot more until we really drilled down into the literature base. And so we used to incidentally say, oh, and by the way, like papilledema, that's cool, but it wasn't what we were primarily looking for. So anyway, we went back for hundreds and hundreds of patients that got some kind of gold standard test, that got neuroimaging, that got an invasive pressure measurement, and we began to try to tease out, like, well, we'll remeasure the height of these bulges and start to try to get to that point of how high is too high in kids. So we just finished some of our initial analysis, and these numbers will probably change as we get into some of the subpopulations that we haven't included in this group. But it's a similar kind of idea that certainly as you get bigger and bigger and bigger in terms of your height, you get more and more specific for having increased intracranial pressure, but you lose some of your sensitivity, right? There's going to be that person that has had increased intracranial pressure for 3 days instead of 30 days, and they're just starting to bulge, and if you ask them to get to 1 millimeter, they won't. So numbers that we're beginning to toss around in terms of cutoffs, if you choose something really low, like the point at which we had 100% sensitivity was like 0.39. And we got so many kids that have like 0.5 that do not have increased intracranial pressure, that saying, oh, well, 0.39 is 100% sensitive. We're going to send so many kids for tests that they don't need if we use that we want to pick something that, you begin to pull the sensitivity down from 100, but the specificity is still high. So 0.65 has that nice balance of high sensitivity, high specificity. 0.8 seems to be the one where you can be 100% sure, and because we had a lot more patients go into our analysis, you can see the confidence intervals are quite a bit tighter, and notably the confidence interval for 0.8 as a cutoff, it's 100% on either end. So that for me is the value where I'm going to be like, look, this kid's 0.9. But one of the tricks is how we generated this literature